ناصر.
ايوه
Please allow
ادخل
to
ابتدي استارت
Yes.
ويبينار.
Yes.
Grazie. Grazie.
ناصر. 5, 4, 3, 2, 1.
Ladies and gentlemen, it gives me great pleasure to welcome all of you in webinar number 21 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. I'd like to express my sincere appreciation to our distinguished speakers, Professor Alberto Dell'Itala. He is a former president of the Italian Society of Neurosurgery, and he is the current president of the Mediterranean Association of Neurological Surgeons. And Professor Abhaya Kulkarni, he is professor of neurosurgery and the director of the pediatric gamma knife program at the Sick Kids Hospital in Canada. Thanks to both of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is highly appreciated. As the second vice president of the World Federation of Neurosurgical Societies, I understand that one of the important missions of our organization is to promote educational activities among all young neurosurgeons, especially in our African continent. May I introduce our first speaker, Professor Alberto Dell'Itala, to give his first presentation. I'm sorry, I think the program will be Professor Abhaya Kulkarni because he has 2 talks. Abhaya, welcome, and can you start to share your screen, please?
Sure, thank you.
Who will speak before, Professor Kulkarni or myself?
Yes, Professor Kulkarni has 2 talks, and so he is going to give his first talk,
Okay.
and then Professor Alberto, and then myself, and then Professor Kulkarni again.
Okay. Can you see my screen here?
Yes, perfect.
Okay. Well, thank you very much. I really appreciate the opportunity to speak to all of you, and of course, during this time, I certainly wish that this could be in person, but it is nice, regardless, to make this connection virtually. It is a great honor, and I thank you very much for the invitation. So I'm going to talk about ETV with choreplexus cauterization and just give the current state of debate and where we are in this topic that's of great interest, really, in the whole world of pediatric neurosurgery. I have no specific conflicts of interest with relations to this talk. Just to begin, the early history of ETV CPC really is the history of choreplexus cauterization or removal of choreplexectomy. So this is over 100 years old now, when some of the very early names in endoscopy and neurosurgery like Lespinasse and Dandy, they were targeting the choreplexus as a treatment for hydrocephalus, using very primitive type of technology with endoscopes and such. And the results were not very good. There was a high morbidity, high mortality associated with it, but there really weren't much other good treatments at that time. Over the next couple of decades, there became a little bit more success in terms of some of the results from endoscopic choreplexus cauterization, but nevertheless, the results were not all that great. You have operative mortalities in the 40s percent. I mean, that's terrible, of course, but this is what they were faced with back in the 30s and 40s. And this was a limitation of their optics, the magnification, lighting, a number of technical limitations that they had. And then once CSF shunts were introduced in the latter half of the 20th century, of course, that became a much more viable means of treating hydrocephalus. And so CPC as a treatment really fell off the wayside and was relatively ignored, except for a few niche centers that kept doing it on a limited basis. And that was pretty much the story for the next 50, 60 years or so. And then what brought about the revival of this procedure was work in Uganda by Dr. Wharf. And so he published in 2005 work that he'd been doing since about 2000 in terms of treating infant hydrocephalus in Mbale, Uganda. And this paper was published in the Journal of Neurosurgery Pediatrics. And I still remember when I first saw it, and I was really impressed and surprised by a number of aspects of this paper. But he was describing a procedure that took that old choreplexus cauterization procedure from the early 1900s and combined it with endoscopic third ventriculostomy. And he was doing this through a single coronal entry site. And he was using the flexible scope to create the ETV and then cauterize the choreplexus of the ipsilateral ventricle. And then, if necessary, do a septum pellucidotomy to use that same entry site to go to the other side. So that it was only done through one burr hole, and you were able to access and cauterize the choreplexus of both lateral ventricles. So this was a new procedure in that sense, combining these two procedures, ETV and CPC, together. And this is what it looks like. This is through a flexible scope. So it's a fairly straightforward procedure. It's a bit tedious because you don't have that much of a cautery surface each time you cauterize. So you have to slowly work your way along the choreplexus. This is the choreplexus of the body of the left lateral ventricle here. And you just move along like this. And it takes some time and patience to get along the entire body through to the glomus and then into the temporal horn. And when you're done, this is kind of what it looks like here in the left lateral ventricle. You can see the blanched white choreplexus there. We've created a septum pellucidotomy here, and we've already cauterized, but I'm just showing you here what it looks like on the contralateral side, the blanched choreplexus in the right lateral ventricle. So that's kind of what you're aiming for at the end of this procedure. And he amassed a huge experience in Uganda. And a number of studies have come out of there, but to summarize what they were able to show with their experience in Uganda is that CPC improves the chances of ETV success in a wide range of etiologies of hydrocephalus, including post-infectious hydrocephalus, myelomeningocele-associated hydrocephalus, and even things like congenital idiopathic hydrocephalus or congenital aqueductal stenosis. So these were all groups where, at least in the Uganda experience, CPC showed that you could add to the success of ETV rather than doing ETV alone. The other thing that was discovered was that choreplexus cauterization appears to have a dose-response effect. And what that means is that doing partial choreplexus cauterization improves your chances of success over not doing any choroid plexus cauterization at all, but doing complete choroid plexus cauterization further improves your chances of success beyond just partial choroid plexus cauterization. So really suggesting that there was something to the not just that you're doing choroid plexus cauterization, but how much choroid plexus cauterization you're doing that has a beneficial effect. And then studies have shown that there was likely no benefit or harm to the survival of a subsequently implanted shunt. So even in the 20, 30, 40% of cases that fail this procedure and then go on to have a shunt, that shunt didn't seem to do any worse in terms of its complications and failure rate compared to if you'd put a shunt in initially. And all those studies ultimately led to a randomized trial that we did at Cure Children's Hospital in Uganda. And in this was a study of infants who were under 6 months of age with post-infectious hydrocephalus, and they were all from neighboring districts around the hospital in Mbale. And they had no major anatomical brain distortions. They had no congenital, other congenital anomalies on CT. They did not have multiloculated hydrocephalus, and they were randomized 1-to-1 to either ETV-CPC or ventricular peritoneal shunt. And so we recruited patients between, for over 2 years, 2013 to 2015. We randomized 100 of them, 51 to ETV-CPC, 49 to shunt. After a month of follow-up, a year of follow-up, 47% were available to be analyzed in the ETV-CPC arm and 47% in the shunt arm. And these were the results that we published now almost 3 years ago. This was the 1-year results, which showed that in terms of the time to treatment failure, although there was a slight benefit to ventricular peritoneal shunt over ETV-CPC, it was not statistically significant, but there was a slight improvement there. But more importantly, we were looking at the cognitive score of these children. What was their development like? And we found, again, no statistically significant difference between the cognitive outcome of these children between either procedure. And this was in our primary analysis, which I'm showing you here, but also when we adjusted for age at randomization and their baseline development score, there was no difference when we analyzed this for treatment as received as opposed to intention to treat. And there were no differences between the treatments for any other BSID score. So the BSID has other scores as well beyond the cognitive score. And similarly, they were no different, and there were no difference from changes in baseline to 12 months. What was different, of course, was the CSF volume. So not surprisingly, with a shunt, you end up with much less CSF in the head than with ETV-CPC. We know this, that the shunts are much better able to reduce the ventricle size to a more normal level. But despite the difference in CSF volume, the difference in brain volume was not significant, so that both groups were able to achieve a similar amount of normal brain volume, even though in the ETV-CPC group, the ventricles were large. And this shows this graphically. So at the top, you've got a patient here who preoperatively had large ventricles and a small brain volume. They get shunted, and then a year later, they have smaller ventricles and a normal brain volume. Okay, so that's a good outcome. Here, on the top right, you have a patient who's got, again, large ventricles and small brain volume preoperatively. They get ETV-CPC, and they still have large ventricles, okay? But they actually have a normal brain volume now. It's hard to tell just looking at these two images, but when you do the 3D volumetric analysis, the brain volume here is significantly larger than it was here, and it's now in the normal range, whereas it was below normal preoperatively. On the other hand, if you look at the bottom row, these are patients who were treated with either shunt, in this case on the bottom left, or ETV-CPC on the bottom right. They're clinically successful in the sense that they don't have symptoms or signs of raised intracranial pressure, but in both cases, postoperatively, their brain volumes are still abnormally low, okay? So that they, even though the treatment seemed to be grossly a success, the brain volumes did not recover like they did for these top patients up here. And that was important because what we found that was those who achieved a normal brain volume had higher cognitive scores, and those who showed more brain growth also had greater improvement in their scores from baseline. And there was a consistent positive correlation with higher brain volume and higher cognitive scores. And we did not see this with CSF volume. So higher CSF volume was not associated with lower cognitive scores. This was something that was only seen with higher brain volume. And then we follow these patients now for longer than that. So we've got the 2-year follow-up, and it's basically the same, okay? This is the 2-year survival curve, again, showing statistically no significant difference, although a slight potential advantage to VPS, but no significant difference in cognitive outcomes or any other surgical outcomes. And once again, at 2 years, brain volume still correlated with all the cognitive scores and change scores, but not CSF volume. What we did find that was interesting, though, is that at 2 years, the increase in brain volume that we had seen at the first year started to stagnate. And you can see that the curve here goes up. These are the brain volumes of all of our study patients. It goes up, and then it either levels off, or in fact, in some cases, starts to go down in terms of the normalized brain volume. And you can see this here, that you know, we went from having 25% normal brain volume at 1 year back down to 3% at 2 years. And in fact, 70% of these patients suffered a substantial relative brain volume loss in that second year, and they all had lower cognitive scores. And we don't know why that is. Now, this study is limited, so it's meant to be addressing a very specific population in Uganda, which is just post-infectious hydrocephalus, which to begin with is a group that's doing very poorly. They have significant brain injury and very low brain volumes, and you could see that from some of the CTs I was showing before, and it's hard to measure cognitive outcome in infants. Now, we do intend to follow this group for longer time, so we'll see what happens at 5 years, for example. But the implications of this is it suggests, first, that with respect to ETV-CPC, even though the ventricle size does not come down with ETV-CPC nearly as much as it does with shunt, it does appear to allow the brain to grow as well as shunt does, which we think is important because brain volume appears to be the more important determinant of cognitive outcome rather than CSF volume. And it brings the question of whether, when we look at a CT scan or an MRI of a shunted patient or an ETV patient, should we be measuring the brain volume and trying to maximize brain growth rather than simply looking at ventricle size? And I think that remains to be answered, but I think there's more evidence that is pushing me towards thinking that that might be the case. Now that's Africa, and not Africa in general, but very specifically one center in Uganda, right? That's all the data that I've given you. So what if we expand that a bit and go beyond Mbale, Uganda? And what about North America? And I put North America here because this is where I practice, but this is where a lot of the literature that comes from outside of Africa deals with ETV-CPC. And it's also where Ben Whorf is now practicing, right? And so he was the originator of this procedure and devised it in Uganda, but then he moved to Boston, where he currently practices, and he's published his North American experience. So this was his initial publication from his Boston experience in 2014, 91 patients, mixed etiology. Overall, he was able to have a shunt freedom rate of 65%. He found that the predictors of failure were those who had post-infectious etiology, those who were very young, those who had pre-pontine scarring, cisternal scarring. That was a negative predictor of outcome, and if they had a prior CSF diversion. The overall 6-month success rate was about 59%, which is higher than the ETV success score. So the ETV success score predicts what the success rate would have been if the children just had ETV. And we would have predicted 45%. But when he added CPC to it, he was able to increase the rate to 59%. And this is what his survival curve looked like, which is not bad. And here compared to what the ETV success score would have predicted. So there was a slight improvement compared to what ETV alone would have likely given this patient population. And if you superimpose on that the expected shunt survival curve from a similar group of shunted infants from our Hydrocephalus Clinical Research Network, you see that there's not a significant difference, maybe a slight advantage to shunt over ETV-CPC, but not that bad. So this was actually quite promising results from Dr. Whorf. The group, however, really is a dichotomous group because he showed, as we've shown in many other studies, that age is a very important predictor. And if you're under 6 months, you do much worse than if you're over 6 months. And if you compare that to the shunt curve here, you can see that over 6-month group actually does really well, whereas the under 6-month group really does quite poorly, with a difference of about 20% improvement compared to shunt. Okay, now he's gone on to do more ETV-CPCs in Boston, and he's published more recent data. And this is unpublished data, but this was presented publicly at the pediatric section meeting in North America in December 2019. And this was his report on 215 now ETV-CPC patients under 2 years of age, compared to 73 shunted patients and 19 in which ETV alone was done. It was a fairly standard mix of patients from a North American perspective, with post-intraventricular hemorrhage of prematurity in about a third, myelomeningocele in a third, and just a little less than that for aqueductal stenosis. And 68% were under 6 months of age. And what he found was that the predictors for reoperation were once again young age, and this time he cut it off at 4 months. So again, young age is a bad prognostic factor. History of prior CSF diversion, as he's shown before, and then a lower Uganda score. And this was the Uganda score. And what this really means is this comes down to the degree of choroid plexus cauterization. So once again, what he's showing is that the less you cauterize the choroid plexus, the lower the success rate is, just like that was shown in Uganda. And this is the survival curve, as you can see here, that freedom with respect to reoperation or VP shunt in the blue arm, which is the ETV CPC arm, versus the red arm, which is the shunt arm. So he's actually showing very good results for ETV CPC here. Now that's in Ben Wharf's hands. So what about if somebody else is doing this procedure? Well, the Miami group is another group in North America that has done a lot of ETV CPC. They started this in 2007, but they use a different technique than Dr. Wharf, where they use a rigid endoscope rather than flexible. And what this means is that they're not able to do as much choroid plexus cauterization as with the flexible scope, and overall their results have not looked as good as Boston's results, as Ben Wharf's results. So this is a study that one of our former residents, who's now on staff, on faculty in Miami, did. This is Shelley Wang's work, where she compared the use of a flexible endoscope to rigid endoscope. And you can see here that the flexible endoscope group in blue seems to do better than when you just use the rigid endoscope. And this is really not just a comparison of flexible versus rigid, but this was a comparison of Boston, i.e. Ben Wharf, versus the Miami group. And you can see that the Ben Wharf's Boston series seemed to do better. And if you did the unadjusted analysis, it was statistically significant that the flexible endoscope was better than the rigid endoscope. However, what Shelley found was that if you do the statistical analysis and you adjust for various differences in the underlying patient population, the age of the patient, the etiology of their hydrocephalus, prior CSF diversion, whether there was pre-pontine scarring, if you're able to adjust for that, then in fact, the difference becomes much less significant. In fact, it's not significant at all. So it's suggesting that the differences that we see here might not just be a technical issue that because of the rigid scope versus flexible, but it might be that the patient population they're treating in Miami is just a more difficult patient population than what Ben Wharf was treating. The other group that's done a fair bit of work on ETV CPC is our Hydrocephalus Clinical Research Network. This is 14 centers from across the US and Canada. And we work together on multiple studies, and I'll talk about that a bit more in my second talk. And this was our data up until 2014. And I show you this graph because it shows how ETV CPC has started to take hold in North America, at least. It was 2012 that we did sort of a somewhat reasonable number of cases, but then there was an inflection point. And then from 2013 up until now, we've been doing a reasonably high volume of ETV CPC cases, averaging over 90 per year across this network of centers. And we've done a few studies on ETV CPC. This is one of them. This was a prospective study that was a prelude to our planned randomized controlled trial, which I'll talk about shortly. But partly what we did here is because we knew how important the degree of choroid plexus cauterization was, everybody was just sort of estimating. You know, the surgeon would do the operation and say, yeah, I cauterize 60% of the choroid plexus, or 90%, or 20%. So we wanted to quantify that a little bit better. So we came up with this diagram that the surgeon fills out right after surgery. And this will quantify for us exactly how much choroid plexus was cauterized. And so we used that in this study. And so we had 118 patients. This was a prospective study, multi-center study, so not one surgeon. There were multiple surgeons across many centers across North America with data that was collected prospectively. And so 118 patients, and you can see that this was a young group of patients. So the vast majority were under 6 months of age. Almost 80% of this population was under 6 months of age, so a very young population. The etiology breakdown you can see here is very similar to what Dr. Wharf had, with myelomeningocele, IVH of prematurity, and aqueductal stenosis as the big groups. If you look at the ETV success score of these patients, it was low, right? So you would expect that this group of patients would have a well less than 50% chance of success with ETV alone. In fact, something on the order of about 35% chance of success with ETV alone. And the degree of choroid plexus cauterization. So when we use that diagram, what we found is that only in about 3/4 of patients were we able to achieve the goals of surgery, which is you really want to cauterize all the visible choroid plexus, which technically we say is greater than 90% or 95% of the choroid plexus. And we were only able to do that in 3/4 of the patients. And I stress that here because what I want you to understand is that these data here, they represent our very early experience with choroid plexus cauterization. We were still learning the technique. And, I do a lot of endoscopy, but I hadn't, before I started this, I hadn't done a lot of flexible endoscopy. And so the big technical part of this was getting better at using the flexible endoscope, for me at least, and I think for anybody who's not used to it. And so I'm just being honest with the fact that when the data that I'm showing you is from when we were still learning this procedure, okay? So I'll be honest, we weren't that great with it because we were only able to achieve this in 3/4 of the patients. If you look at the complications here, the one that disturbed me was the rate of seizures. So this is an infant population, and these surgeries, at least when you're starting out, they take a while. You sometimes go through a lot of irrigation. There's a risk of developing some degree of postoperative subdural hematoma and stuff. And it's a relatively long procedure when you're first starting out. And our seizure rate was higher than I would have liked, about 5%. So that's something that worries me about this procedure. And this was our early experience, and the results were not great, right? We had about a 40% success rate overall with this. You can see that the predictors of ETV success were generally predictable, with age, again, being a negative, young age being a negative predictor. And once again, the surgeon estimate of choroid plexus cauterization was a strong predictor of success. And then visualization of a naked basilar artery, meaning that you were able to do a good ETV and clear out any residual membranes. That was a strong predictor of success. And when we did a matched historical cohort, a shunt comparison cohort, you can see here that the results were not very good. It suggested that shunt does quite a bit better than ETV-CPC with respect to survival. So we weren't happy with this, but again, I stress these were our early results, and our subsequent results with this, once we got better at this procedure, have been better for this. But as we're moving along, we're learning about ETV, CPC. I think we're still learning and evolving how we do this procedure and who we do this procedure in North America, at least. And I will tell you that based on the most recent data analysis that we've done, the way we're generally applying this procedure right now is using it in this group of patients. Infant hydrocephalus under 2 years of age, for anybody who has myelomeningocele and is greater than term corrected age. If you have preemie IVH, so intraventricular hemorrhage of prematurity, and you're greater than 6 months corrected age, which again, that's a very rare group of patients, right? It's very rare that you've got somebody with who's born premature, has intraventricular hemorrhage, develops hydrocephalus, and then doesn't need treatment until they're over 6 months corrected age, right? Which is often 8-9 months of actual age. Postnatally, so that's a rare group of patients. We generally exclude post-infectious because they don't do well, but we've had some exceptions to that. And then for anybody else, we do it after their 1 month corrected age. But they also have to have favorable third ventricular anatomy, and they have to have no obvious adhesions in the pre-pontine cistern. And we do detailed cis and fiesta images in the sagittal plane to look very carefully at that pre-pontine cistern to make sure that there's no significant adhesions there preoperatively. And importantly, we review these cases amongst each other. So we ask each other's opinion to see that everyone agrees that ETV-CPC is good in this context. But there are a number of questions that need to be answered in North America. And I think one of them is there a minimum age under which the success rate is too low? Maybe it's under 1 month, maybe it's under 3 months, but I think it's etiology specific, and that's why we've come to the criteria that I mentioned in the previous slide. Are there certain etiologies for which ETV-CPC is not useful? And I think post-infectious hydrocephalus may be one of them. And this is, keep in mind that the post-infectious hydrocephalus that I'm talking about in North America is quite different pathophysiologically than the post-infectious hydrocephalus that is seen in Uganda. Very different types of infections, and I think the pathophysiology of the hydrocephalus is also different. So even though this procedure works well in the Ugandan post-infectious population, it has not worked well in the North American post-infectious population. And are there certain etiologies on the flip side for which CPC adds very little? And I think with some of the data that's coming out, I haven't shown it here for sake of time, but some of the data that's coming out on older infants who are over 6 months of age with a pure aqueductal stenosis, data is showing that they do very well with ETV alone. And that's a group that I'm not sure I would add CPC to that, because that adds morbidity and time to the procedure. And I don't know that in that group of infants over 6 months of age with aqueductal stenosis alone, that CPC adds much. The bigger question I find, though, is that how low a success rate are parents willing to tolerate for the possibility of shunt freedom? So having a shunt and shunt dependency has gotten a really bad name. And so we'll have parents that come to us, and knowing that I do this procedure, and say, we'd like you to do this procedure on our baby, and I'll look at their baby and I'll say, look, this is not your baby's not a good candidate for this procedure. I could do this procedure, but the chance of success is 20-30%, and there's all these risks associated with it. And sometimes the parents will say, no, we understand that, we still want you to do this procedure. And ethically, that's an interesting dilemma, whether you allow yourself to do something that you think may not be in the best interest, even if the parents know what they're getting into. So we don't have clear answers on this, but I will tell you that we've just embarked on a very large multi-center randomized trial in North America that's run through our Hydrocephalus Clinical Research Network. It's a very expensive, $10 million US study that's going to run over 7 years. And this is modeled very much after the El-Ghandour RCT that I just told you about. The criteria are different. So we're going to have infants under 24 months of age. We're excluding intraventricular hemorrhage of prematurity. The primary outcome will again be a cognitive outcome. So we're going to look at the survival curves and the Kaplan-Meier survival curves. But what's more important is going to be the cognitive outcome at 12 months. But we're going to follow them longer term as well, to 5 years. And we're going to have cognitive outcome. We're going to have quality of life. We're going to have a detailed imaging outcome, including diffusion imaging on MRI, and we're going to have CSF biomarkers. So it's going to be a very detailed, comprehensive, prospective randomized trial. Recruitment has just started. We just this week randomized our first patient here in Toronto. That's the second patient randomized in the study. So we're moving along with this. It's going to take a while, but hopefully in the next few years there'll be some data that I can share with you. And with that, I will end, and thank you very much for your time.
Thank you, Professor Kulkarni, for this very, very fascinating presentation. I'm very happy to hear from your experience of operating in patients or in children in Uganda. Actually, as CANS, we are too much concerned about neurosurgical education in sub-Saharan Africa. Thank you very much for this presentation. I think we will do questions and open discussion at the end of the webinar. Let me first introduce Professor Dr. Omar Youssef. He's the moderator of this session with me. And we have also Professor Osama Al-Ghannam in the panel. Professor Osama Al-Ghannam is Honorary President of the Egyptian Society of Neurosurgery and the former Dean of the Faculty of Medicine at Azhar University. Let me also introduce Professor Hisham Basyouni, Professor of Neurosurgery in Germany. They are among the panel, and me and Omar will moderate this session. Omar, can you introduce Professor Alberto for the next talk?
Yes, first of all, thanks to Dr. Kulkarni for this nice presentation and for the introduction of the CPC to solve some of the problems of ETP in infants. Thank you, Dr. Kulkarni, and we would like to welcome Dr. Diritala for his sharing his experience with us in this webinar. I think Dr. Diritala is going to speak on the pitfalls and contraindications of ATV. Yes, welcome, Dr. Diritala.
Yes, I'm trying to share my screen. Can you see everybody?
Yes, perfect.
Okay. First of all, I want to add my congratulations to Professor El-Ghandour for organizing this meeting. I want to remember that in this period, Nasser El-Ghandour was going to organize the 5th Men's Congress in Cairo. And everybody knows that was a very strong effort to do this, but COVID period delayed our hopes. And so again, my congratulations to Nasser El-Ghandour for doing this and to try to do the Congress in Cairo next year. I was impressed by the presentation of Professor Kulkarni because he touched an argument really not so known. So the choroidal plexus coagulation that is still under discussion, but he showed us how can be hopeful and how can be discussed in the future. My talk will be about the pitfalls and the contraindications in endoscopic third ventriculostomy. It is a long history. I can show you here the flyer of our fourth course of endoscopic neurosurgery in Rome, held in Rome just 20 years ago. And so the history of endoscopy, as we saw, is now starting to be long and very, very promising. But we have to say before that we have to divide the hydrocephalus in adults population and in pediatric population. As we saw, the pediatric population is a completely different population, and also the indications for ETV are a little different. In the pediatric population, the morbidity due to hydrocephalus is estimated in 1.2 every 1,000 of children, so very important. Hydrocephalus can be classified as a communicating or not communicating hydrocephalus, depending of the level of obstruction of CBS flow. The obstructive hydrocephalus is a long-standing compensated hydrocephalus state, as long as clinical presentation appears more commonly with age, gait disturbance, memory disturbance, incontinence, blurred vision, tremor, seizure, swallowing difficult, rarely Parino syndrome. The asymptomatic aqueductal stenosis is the most common reason of this condition, and the prophylactic surgical intervention with the ETV shows good results. The secondary non-communicating hydrocephalus, the so-called obstructive hydrocephalus, has a typical presentation with more acute symptomatology and accompanying imaging of periventricular edema. The pineal region tumors are the prototype of this hydrocephalus, and in these cases, ETV should be considered as the primary treatment. Also, if for periventricular tumors and intraventricular lesions, ETV is not the appropriate treatment for all the patients. So we have to share to select a patient and to select a treatment. In the adult hydrocephalus, the symptomatology varies. For young patients are most likely to present headache, nausea, sixth nerve palsies, and declining consciousness. Elderly patients typically present with signs of and symptoms of so-called normal pressure hydrocephalus. Many cases of communicating hydrocephalus occur after subarachnoid and or ventricular hemorrhage, particularly as a consequence of aneurysm rupture. Other cases are sequelae of meningitis or ventriculitis. The treatment has traditionally been by CSF shunting procedure, and in some cases, ETV appears to be an effective treatment, also if is not really intuitive. The ETV endoscopic third ventriculostomy, as we saw, can be performed by rigid endoscope or flexible endoscope. Everybody knows that with the rigid endoscope, we have a much better view of all the structures. And with the flexible endoscope, we can move inside the ventricles without particular risk. With rigid, we have to stay straight in our direction. ETV, the success rate of endoscopic third ventriculostomy, it has been demonstrated an ETV, sorry, I have to delete some, yes, okay. This is demonstrated that the success rate is high, but actually the success rate is estimated between 40 to 85%. It depends principally by the indications of the endoscopic third ventriculostomy in hydrocephalus. So the evaluation of success rate can be done by the so-called folding sign. This is a prediction of effectiveness of endoscopic third ventriculostomy. The folding sign is when we perform the third ventriculostomy, we can see some, we can see some folding areas just here in the running in the longitudinal direction. It appears only when the third ventriculostomy is sufficiently open, and its extent varies from faint to obviously depending on individual cases. So this sign can be assumed as a good predictor of success evaluation. The second, but not least, is the opening of the stomia. The stoma has to be opened at least to perform the passage of the rigid endoscope. This is the good measure, and if we don't open enough the stoma, we don't have a good passage of CSF. The failure rate of third ventriculostomy is estimated in about 34–35% of the cases. The patient with the chronic meningitis respond poorly to endoscopic third ventriculostomy, and as I said before, another reason for technical failure is the so-called incomplete opening of the Lillquist membrane. In the pediatric hydrocephalus, the role of ETV is not still completely clear. Also, if we see that if the patient is less than 6 months old, the successful rate is very, very low. So we have to exclude the indication of third ventriculostomy in a very, very young, very early patient under 6 months of age. There is a recent paper in which they tried to perform some, to state some score, the so-called ETV success score, and it is based on age. Less is the age, less is the success. The post-infection is not a good indication. And in a young patient, the previous shunt is not a good indication. This is contrary about our experience in which the already shunted patient, but I speak about adult patients, are well responder to endoscopic third ventriculostomy. Another success rate predictor is the so-called third ventricular floor bowing. The third ventricular floor bowing is an indicator of obstructive hydrocephalus resulting in higher success rate with endoscopic third ventriculostomy. It is due to a ballowing of the third ventricle to indicate a pressure differential between these structures. Bowed if depression of the anterior or posterior third ventricular floor below a reference line, enlargement of the supraotic recess, anterior curvature of the lamina terminalis, dilatation of the proximal aqueduct, enlargement of the suprapineal recess. This is the so-called third ventricular floor bowing. We have not to forget the ventricular peritoneal shunt because we have to remember that we have to follow very strict the patient underwent to third ventriculostomy. Because as Calcarni said, Professor Calcarni said before, in the third ventriculostomy, we have not a clear reduction of the ventricle size, and sometimes also the sign of the good cistern reapparization is not so clear, and so we have to underwent patient to a strict follow-up. This is, I think, the major limit of third ventriculostomy, of endoscopic third ventriculostomy. We have to say that in the adults, when shunt, when we are in presence of shunt failure, more than 70% of endoscopic third ventriculostomy is effective. This is a paper in which we participated with the Italian Society of Neurosurgery. So there is this difference. In adults with the shunt failure, ETV is a good indication. With in young, in children with the shunt failure, ETV is not a good indication. Another chapter, another issue is for a so-called normal pressure hydrocephalus. Normal pressure hydrocephalus is a distinct pathology. This is thought to as a model clinical presentation of hydrocephalus in elderly. The clinical presentation is also not limited to classic triad, with some patients presenting with Parkinson symptoms. Currently, the most accurate test to predict shunt responsiveness is the external CSF lumbar drainage. Improved observed in 64 of patients at 3 months, but only at 26% at 3 years. And so the improvement is not so high. This is a case in which he was completely asymptomatic, and he came to us with this very huge hydrocephalus. And these are typical cases in which it's very difficult to take any decision. If we see the ventricle sides, you say, okay, it's better to put a shunt. But this patient underwent a shunt in another hospital, and he had a subdural hematoma. And so after the removal of the shunt, he was completely good. He underwent a third ventriculostomy and endoscopic third ventriculostomy, but up to now, this is the result. Our decision is not to do anything because the patient is completely asymptomatic. And so we have a large number of cases in which the decision is very difficult. Now we go to ETV complications. The overall complication rate varies from 5 to 15%. There are many reports about the complication rate. We can distinguish in immediate complication rate, immediate postoperative, reported the rate of CSF leak from the skin. It varies from 0 to 5.2%, and reported rate of infection varies from 0 to about 6%. Intraoperative incidents, reported rates of intraoperative bleeding vary from 0 to 8.5%. General septal rate of considerable hemorrhagic incident during endoscopic third ventriculostomy is 4%. Basilar rupture, that is a tragedy, is reported in 0.2% of cases, and injury to neural structures is very low. Late events, permanent neurological morbidity is due to ETV is estimated 1.2%, and overall rate of permanent hormonal morbidity is 1% about. So I thank you very much for your attention, and I can say stay safe, and we hope to meet again probably in Cairo next year. Thank you.
Thank you very much, Professor Alberto De Letala, my friend, and it was very wonderful presentation, actually. And I'm sad too that the Third Man's Congress, which was supposed to be held in Egypt this month, will not be organized, but hopefully this pandemic will be finished soon and we can make it next year. It is already scheduled at the same time and at the same venue from 27 to 30 October 2021 in Cairo, in Egypt. And we are honored, I'm honored to work with Professor Alberto De Letala, the president of the Mediterranean Association of Neurological Surgeons. Professor Omar Youssef.
Yes, I would like to thank Dr. De Letala for this valuable experience. He shared his valuable experience with us through raising multiple issues in the dilemma of the hydrocephalus all over. Thank you, Dr. Tara, for this very nice presentation. And now I'd like to introduce Dr. Nasser El-Ghandour, Professor of Neurosurgery, Cairo University. He is the president of Egyptian Society of Neurosurgeons. He is going to speak about the challengeable issue in the field of the pediatric problems in neurosurgery. He spoke about the endoscopic treatment of complex hydrocephalus. Yes, welcome, Prof.
Welcome, everybody. I'm going to speak today about the endoscopic treatment of complex hydrocephalus. Definition, it is any form of hydrocephalus which cannot be treated with a single neurosurgical intervention, whether shunt, ventriculostomy, or cyst fenestration. Actually, complex hydrocephalus is a difficult problem in pediatric neurosurgery. Classification. Complex hydrocephalus is classified into uniloculated hydrocephalus and multiloculated hydrocephalus. Uniloculated hydrocephalus, which means the presence of a single cyst or loculus inside the ventricular system. Multiloculated hydrocephalus, it means the presence of multiple cysts or locules isolated by multiple intraventricular septations. As you can see in the magnetic resonance imaging, the ventricular system is transformed into a group of cysts or compartments which are isolated from each other. Such condition, we call it polycystic brain. It is the same like polycystic kidney. Complex hydrocephalus can be simply classified into supratentorial hydrocephalus and infratentorial hydrocephalus. And I was looking in the literature, I found another classification, which was published in 2012, where complex hydrocephalus was classified according to the anatomical complexity and according to the cerebrospinal fluid absorption. It was classified into simple uniloculated, complex uniloculated, simple multiloculated, and complex multiloculated. However, such model is difficult to apply within a clinical setting because disturbed cerebrospinal fluid absorption is a diagnosis of exclusion. Etiology. Usually uniloculated hydrocephalus is congenital in origin, whereas the most common cause of multiloculated hydrocephalus is neonatal meningitis, followed by intraventricular hemorrhage and postoperative gliosis, which is usually secondary to shunt infection. The common factor between these three causes is the ventriculitis. It seems that ventriculitis, whether it's chemical or infectious in origin, will probably encourage subependymal glial tissue proliferation, upon which exudates and debris organize, and this leads to septa formation. As we can see from this image, the consequence of absorption of intraventricular hemorrhage is the formation of intraventricular septations as seen in the magnetic resonance imaging after 3 months. Diagnosis, my advice, we are now in educational symposium, and I'm now speaking with young neurosurgeons and residents who are seeing children with hydrocephalus. We have 2 pediatric hospitals in Egypt. Actually, they are the 2 biggest hospitals in the Middle East. And in one clinic, the resident can be able to see about 100 cases of hydrocephalus. And that is very increased rate of hydrocephalus. And my advice, when to suspect the diagnosis of complex hydrocephalus, if you find disproportionate hydrocephalus in CT scan, please ask for magnetic resonance imaging and remind you that gadolinium is very important because if you don't give gadolinium to the patient, you will not be able to recognize all the interventricular cysts. In order to make definite diagnosis, you can use CT ventriculography, which will also confirm that these cysts are not communicating with the ventricular system. Such investigation I'm not using routinely in my patients. Look at this image, the left side before operation, and the right side CT ventriculography after doing endoscopic fenestration. And you can notice that the contrast material is filling the entire ventricular system, which confirms successful endoscopic cyst fenestration. Traditional treatment for classic teaching, stereotactic aspiration is one of the methods of treatment. However, it's associated with more than 80% incidence of recurrence, and it's not used nowadays. The second line of treatment is multiple shunting. I hate inserting shunts in the ventricular system, simply because it is usually associated with high incidence of complications and malfunction. The third treatment option is microsurgical cyst fenestration, either through transcortical or transcallosal approach. And finally, and recently, the endoscopic treatment. Let us look at the history. The first case of loculated hydrocephalus was operated in 1908 by Harvey Cushing, whereas the first case of multiloculated hydrocephalus was operated in 1972 by Roten and Gomez. They used microsurgical fenestration, whereas all compartments were opened via small corticectomy, and a single shunt was inserted. The first successful endoscopic fenestration was performed in 1982 by Kleinhaus et al. A child who had a left ventricular cyst was operated using a bronchoscope. They created a channel between the cyst and the ventricular system. In 1986, Powers performed endoscopic fenestration of ventricular cyst using a flexible, steerable endoscope and argon laser. In 1991, Hellman and Cohen described the endoscopic treatment of 3 patients with ventricular obstruction using saline torsion. What is the role of endoscopy in complex hydrocephalus? The classic procedure is endoscopic cyst fenestration. However, there are other important roles for endoscopy in dealing with these children. Endoscopic shunt retrieval, it is an absolute indication to use endoscopy in order to avoid intraventricular hemorrhage. Endoscopic shunt revision under endoscopic guidance, new shunt placement, shunt simplification. And by shunt simplification, we mean replacing multiple shunts by a single shunt consisting of one ventricular catheter, one peritoneal catheter, and a reservoir. Endoscopic third ventriculostomy, but remind you that it's very difficult to do endoscopic third ventriculostomy in complex hydrocephalus, simply because the anatomy is usually distorted to the extent that usually you are unable to identify the third ventricle. We started to operate on these patients in September 1998. We have about 22 years experience. We presented our results in San Diego in the annual meeting of the Congress of Neurological Surgeons in October 2001. Our first study included 18 patients with loculated hydrocephalus operated by endoscopic cyst fenestration. It included both divergent types of complex hydrocephalus, uniloculated and multiloculated, and all the patients had supratentorial hydrocephalus. Then we increased the number of cases and re-presented our results again during the annual meeting of the Congress of Neurological Surgeons in October 2006 in Chicago, Illinois. I then studied each type separately because I realized that both types are completely different in pathogenesis. Uniloculated hydrocephalus is congenital in origin with an affected subarachnoid space, whereas multiloculated hydrocephalus is post-infectious or post-inflammatory with obliterated subarachnoid space. I was the first to recommend separating both types. Look at this table, which compares between the 2 types of complex hydrocephalus. As we can see, uniloculated hydrocephalus is usually congenital in origin with unaffected subarachnoid space. And usually the treatment is successful and the outcome is good. Whereas multiloculated hydrocephalus is usually post-infectious or post-inflammatory with obliterated subarachnoid space. The treatment usually is non-successful and the prognosis is bad. This is our first study published in 2006 in neurosurgery. When we go back to the literature, we find that the first study about complex hydrocephalus was from the United States of America. It was published in the Journal of Neurosurgery in 1995, and it included both types, uniloculated and multiloculated. The second study was from Poland. It was published in the Child Nervous System 2003, and it also included both types of complex hydrocephalus. The third study was from Egypt. It was published in the Journal of Neurosurgery 2008. It included only multiloculated hydrocephalus. And the fourth study was also from Egypt. It was published in the Journal of Neurosurgery 2013, and it was specific for the endoscopic treatment of uniloculated hydrocephalus. This is our first publication in the Journal of Neurosurgery about endoscopic treatment of multiloculated hydrocephalus. And this is another publication about endoscopic treatment of uniloculated hydrocephalus in the Journal of Neurosurgery. Let us think together how to approach the problem. As I said before, it is a difficult problem in pediatric neurosurgery. And our goal is to find out how all cerebrospinal fluid containing compartments can be connected to each other. Remind you, the disease has often not yet reached its final stage when the case is presented to you, and you should expect a high incidence of postoperative recurrence and reclosure. The most important thing while approaching this problem, you have to make a proper selection for the entry point. If you select the burr hole in the most important point, that's very crucial for these patients. And also selecting different trajectories in order to fenestrate as much cyst as possible. You can use a single burr hole and you can use different trajectories in order to fenestrate many cysts. And remind you that it is impossible to fenestrate all the cysts during the first operation. And it's normal to have repeated procedures in the management of these patients. Avoiding shunts. Is it possible to avoid shunts in complex hydrocephalus? The role of endoscopy is usually limited to doing fenestration. Patients usually still need shunt to treat the hydrocephalus. And again, remind you that the pathophysiological mechanisms that cause septations are responsible for deficiency of the absorption capacity of the subarachnoid space due to scarring of the arachnoid granulations. Planning the operation, how to plan the operation. As I said before, it is very crucial to make a proper choice for the entry point. And it's very crucial to choose your trajectory properly. I like to operate through a single burr hole in order to avoid the entrance of air. Other neurosurgeons can operate through uniportal or biportal technique. Usually I'm working freehand without fixing the endoscope. I'm using this lens. It is a rigid lens, 2 millimeter diameter with working channel, straightforward, wide angle with angled eyepiece and working channel through which I can introduce the instruments. I like to use rigid lens due to greater light intensity and superior optics, which allow better visualization. You can use the flexible endoscopes, but I advise young neurosurgeons to start by the rigid endoscopes because using the flexible endoscopes require a significant amount of expertise. Look at this diagram. I will show you how to select the trajectory. In this patient, look at the mouse. If you go from the frontal horn by the endoscope, you will not be able to fenestrate except one cyst. But if you go through the occipital burr hole, you will be able to fenestrate all the cysts and communicate them together and communicate them with the ventricular system. Intraoperative findings. I have to tell you that that's a complex disease. And you will be, as expected, you will find the membranes opaque. You will find that the anatomical landmarks difficult to be identified. The anatomy is muffled. The membranes are usually multilaminated, and they are usually very tough to be fenestrated. You should comment either the fenestration single or multiple if the communication is adequate depending on the flow of CSF and movements of the membranes. If there is intraoperative bleeding, whether venous or arterial, sometimes I like to devascularize the cyst wall in uniloculated hydrocephalus using the bipolar in order to retard or prevent post-operative regrowth. Another important point is the intraoperative localization. How to localize these cysts? It's not an easy procedure. You can use intraoperative ultrasonography, you can use neuronavigation. I didn't use both of them, but I was depending mainly on multiplanar magnetic resonance imaging with gadolinium. And after getting more experience in dealing with these patients, and after developing a good learning curve, it will be possible for neurosurgeon to differentiate between these membranes and ependyma. These membranes are usually mobile with cerebrospinal fluid pulsations. Usually they are light blue in color, variable in thickness, and translucent in early cases. Very important technical considerations. What is the size of fenestration? I usually do very wide fenestration, so long that safety is ensured. This is due to the high incidence of post-operative reclosure. And this is attributed to two important causes: the low pressure differential, which exists across the cyst walls, and the inflammatory origin of the disease. Another important question: are you going to use blunt perforation or sharp perforation? By blunt perforation, it means that you are going to fenestrate using the tip of Fogarty catheter, and that is risky. When I started to operate on these patients, I was using blunt perforation until I realized that I was exerting more pressure on already stretched membranes, and that is risky because it can induce more damage on already damaged brain. Another important question: which to do first, endoscopic cyst fenestration or cystoperitoneal shunt? I like to do both at the same sitting, but I like to do endoscopic cyst fenestration first, because if you go ahead and insert the shunt and then you do fenestration and you can encounter some intraoperative or intraventricular bleeding, this shunt will be obstructed later on. So please do the endoscopic cyst fenestration and then insert the shunt. Another important question: to leave external ventricular drainage. I don't recommend leaving external ventricular drainage except if there is bleeding, because it can lead to cyst collapse with post-operative subdural effusion, and at the same time it interferes with cerebrospinal fluid pressure gradient, and this can lead to post-operative reclosure. I will show you some cases. Look at this patient. This is uniloculated huge intraventricular neuroepithelial cyst obstructing both foramina of Monroe. Let me show you the video. The cyst wall is bluish in color. That's example of sharp fenestration using the bipolar coagulation. It's more easy than blunt fenestration, as I just said now. Now you will notice that the cyst, now there is movement of the membrane and flows of cerebrospinal fluid, which means that the fenestration is adequate. And you can notice collapse of the cyst, and you can notice here that the foramen of Monroe is opened. This is the foramen of Monroe after collapse of the system. Successful fenestration. Or the image on the right side, the magnetic resonance imaging, is done 3 months post-operative. As you can notice, there is improvement of hydrocephalus, restoration of ventricular architecture, and increase in the cerebral mantle. The photos of this patient, the intraoperative photos, had been chosen as the cover image of the Journal of Neurosurgery. Let me show you another case. This is a boy 7-month-old who had complex hydrocephalus due to toxoplasmosis intrauterine infection. And these images 3 months after operation showing improvement of hydrocephalus. 1 year after operation, the result is marvelous with almost complete resolution of hydrocephalus and restoration of ventricular architecture. Let me show you the video of this patient. This is example of blunt perforation. Now we are perforating using the tip of Fogarty catheter. Look at the amount of stretch you are inducing on already stretched membranes. I don't recommend blunt perforation while dealing with these patients because this can risk more damage to already damaged brain. Look at the membranes. As we said that usually the membranes are complex, they are opaque, they are tough, they cannot be fenestrated easy, and usually they are multi-laminated, many layers, as you will see now, because the disease is complex in nature. That's why it had been called complex hydrocephalus. Another patient, 1 year old, this patient came with 3 non-functioning shunts. We call it complex shunts. By endoscopy, we were able to remove 2 shunts safely and to do endoscopic revision of the 3rd shunt. This image taken 3 months post-operative showing improvement, and this image taken 1 year post-operative. As you can see, there is significant improvement of hydrocephalus, restoration of ventricular architecture, increase in the cerebral mantle, and opening of the subarachnoid space, which denotes that the result was very good. Let me show you the video of this patient. This ventricular catheter is adherent to the membranes. And the message is very clear. Never try to retrieve adherent ventricular catheters in complex hydrocephalus without being dissected under endoscopic guidance. Because if you do, if you pull it without dissection, that is very dangerous and you can risk intraventricular hemorrhage. Another patient, girl, 1.5 years, and this patient was operated through 2 bare holes. She was operated through left biportal technique, 2 bare holes, 1 frontal and 1 occipital. I was able to do endoscopic 3rd ventriculostomy in this patient, as you can see now. You can see both mammillary bodies and the fenestration in the floor of the 3rd ventricle. And I will show you a catheter which was introduced from the occipital bare hole. Can you see this? And it denotes successful fenestration. And you can see the image on the right side taken post-operative 3 months, and it shows significant improvement of hydrocephalus, restoration of ventricular architecture, increase in the cerebral mantle, and opening of the subarachnoid space. Let me show you our results in multiloculated hydrocephalus. I will show you in multiloculated because uniloculated, the results were much better. But first of all, I was not able to do a long-term clinical follow-up for the patients included in this study, but it was possible to achieve 75% improvement radiologically. It was possible to avoid shunts in 12.5%. Simplification of complex shunts was possible in 50%. And it was possible to reduce the shunt revision rate from 2.9 per year to 0.2. Morbidity, 8% incidence of cerebrospinal leakage, which stopped spontaneously without any operation. And minor bleeding occurred in 2 cases in 8%. And it was not significant, and it did not require termination of the procedure. However, both patients later on, they needed repeat endoscopic procedure, and subdural hematoma in 1 patient, which is about 4% incidence. We had recurrence in 8 patients among 24 patients, which constitutes about 33%. Among a follow-up period of about 30 months, and all of these patients needed repeat endoscopic cyst fenestration. Let me show you the case of morbidity. You can see that This patient immediately post-operative has huge bilateral subdural hematomas, which resolved conservatively. And you can notice here inside the ventricle, there is fluid level of intraventricular hemorrhage. And 3 months later on, there is complete resolution of the bilateral subdural hematomas. And you can notice the formation of new septum at the same site of the fluid level of intraventricular hemorrhage. As we said, the consequence of absorption of intraventricular hemorrhage is the formation of intraventricular septa. Important notice, all the patients in whom shunts placed before endoscopic cyst fenestration needed a repeat endoscopic cyst fenestration. However, none of the patients in whom endoscopic cyst fenestration preceded shunt placement required shunt revision. In other words, patients who have shunts placed before endoscopic cyst fenestration had a 7.5-fold risk of having repeat endoscopic procedure, more than the patients in whom endoscopic cyst fenestration preceded shunt, which can make a clear conclusion that early diagnosis and treatment gives the best results. And this can be explained by the thinner septations, easier fenestration, less vascular cyst wall, and less likelihood of reclosure. Endoscopic cyst fenestration gives better results in uniloculated than multiloculated hydrocephalus, and both types should be studied separately. And I would like to stress about important point before closing the lecture that remind you when the disease is complex in nature, the treatment is also complex in nature. The treatment is challenging. People can think that by communicating the cysts together and communicating the cysts with the ventricular system, the problem is finished. That's not right, because we still have another more complex factors. We have immaturity of the subarachnoid space. Most of these patients are infants. Usually they have scarring of the arachnoid granulations with deficient absorption capacity of the cerebrospinal fluid. And because of the inflammatory nature of the disease, progression or regrowth of the membranes is common after these operations. We organized many workshops, hands-on workshops in Egypt about ventricular endoscopy. This gathering photo in Ritz-Carlton Hotel with the president of the World Federation of Neurosurgical Societies, Franco Servadier, and faculty, Professor David Giminier, Professor Andrea Grottenhaus, Professor Mahmoud Khorashi, Professor Omar Youssef, Professor Ramis Korolos, another gathering photo in Egypt 2019. And I think Professor Alberto De Litala was among the faculty of this course. And we are organizing regularly 1 or 2 courses about ventricular endoscopy in Egypt. Hopefully this COVID-19 pandemic will be terminated soon, and we are going to restore our activities. We are offering scholarships for candidates. Please communicate to me through this email in case you have any questions or any comments about this presentation, or if you would like to join our courses or our meeting next year. Thank you.
Thank you, Dr. Nasser, for this nice presentation, especially on a quite challengeable issue, which is the complex hydrocephalus. Now I would like to introduce again Dr. Kulkarni about a very interesting topic. I think it would be quite valuable for us. He will speak on the multicentric international studies in hydrocephalus, lessons learned from personal success and failures. Yes, welcome, Dr. Kulkarni, please.
Great, thank you very much. This is a very different type of talk, and I hope it's of some use. I'm not going to talk a lot about science at all. This is it's a very personal talk about collaborations that I've been involved in, some of which have worked and been successful, and some of which have not. And I just hope that just you learn something from this and maybe get some inspiration and heed some warnings as well. So the goals of this is I'm going to discuss some of the collaborative studies in hydrocephalus, primarily to illustrate different models of academic collaboration, because there's different ways you can collaborate across centers and across countries. And in particular, I'll highlight what I think have been some of the successful collaborations that I've worked in, but also some of the failures, and then we'll talk about the overall benefits and disadvantages of large-scale collaborations. And so these are the collaborations that I'm going to talk about. And again, this is very personal. There's many collaborations that happen all over the world. I've chosen these because these are the ones that I've been involved in. So I know them well, and I can give you some background and some personal insight into them. There's a Canadian pediatric neurosurgery group, which was just an informal group defined by geography and a common interest. The ISGNE, which has now become the IFNE, a group of common interest that occasionally works together on projects. The IIHS, which is a formal collaboration for a specific study. The Uganda collaboration, I've showed you the results of that already in my previous talk, but I'll talk more about the background and how that collaboration took place. And then the HCRN, the Hydrocephalus Clinical Research Network, which is a more formal multi-center self-sustained network. And again, I've shown you some of the results of that work in the previous talk, but now in this talk, I'll talk more about how the HCRN comes together and how it functions. And this is something that I'm really proud of. So when I go over all these collaborations, these are the countries and places around the world that these collaborations involve. So it's really very international, and really something that I'm very proud of and very happy about to be part of. So I'll start with the CPNSG, the Canadian Pediatric Neurosurgery Study Group. This is a very informal group, and this was started by Jim Drake in 2001, and it was meant as a means to gather the roughly 25 to 30 pediatric neurosurgeons across Canada in one place. And so we meet every February at a site across Canada. It changes every now and then, and it serves different purposes. So often it's just to present difficult cases and get other people's opinions. We may discuss social, economic, political issues that are relevant to pediatric neurosurgeons across Canada, but also a large part of it is meant to talk about research and ways to collaborate on research proposals. And February in Canada is not all that pleasant a time to be in Canada, but the way we get people to show up is that we hold meetings at places like this. So in Banff or Whistler, beautiful ski resort areas where people are willing to come out, and we get a lot of people coming out. So typically about 60 to 70% of the pediatric neurosurgeons in Canada will show up to this meeting every February. And we get research ideas that are presented, but not all of them come to fruition, right? So that people will come with an idea and they'll look for people to collaborate with. Some centers collaborate, some centers don't. And it doesn't always end up in a successful project. But there have been some successful projects. So there's been work on thalamic tumors, definition of surgical complications. There's been a seizure outcome database that's ongoing. And then we've looked at ETV outcome as well. And this is one of the more successful things that have come out of this Canadian pediatric group. So this was the paper, this is the first paper that came out of this group, and this was Jim Drake led this, but he wrote this on behalf of the Canadian Pediatric Neurosurgery Study Group, as you see here. And what was really important about this was in the appendix, listing all the different surgeons who contributed to this paper and to this study. And this is the first lesson that I will present from what I've been involved in international research, is making sure you know whoever you're collaborating with, who they are and what their interests are and why they're working on this with you. Okay, what do they want from this collaboration? And usually it's about making sure that aside from just getting research answers, that those individuals receive appropriate academic credit for what they're doing, meaning that their name goes on the paper and that they're acknowledged for their contributions. And that's important for collegiality, fairness, and for maintaining future successful collaborations. And I would encourage that there be a common a priori understanding of how people will be credited, and that it should be in writing, so that even before you start collecting data, you say, this is how the authorship of the paper is going to be, this is the order of authorship, and this is where your name, Dr. X, is going to appear for having collaborated in this work. And then from that Canadian Pediatric Neurosurgery Study Group data, that was a large part of the data set that eventually led to the development of the ETV success score. There were other collaborators as well that participated in this, but it was a Canadian Pediatric Neurosurgery Study Group that played a large role in the development of the ETV success score. And so if you look at, since 2007, these are the most highly cited papers on endoscopic third ventriculostomy. And 3 of them are related to the Canadian Pediatric Neurosurgery Study Group. They used data from that study group. So 3 of the top 5 most cited papers on endoscopic third ventriculostomy have come from that collaboration, which I think suggests that it was quite useful. And it cost no money. This was people working on their own for nothing. Now, the other collaboration is the ISGNE, which is now the IFNE. This was originally founded in 2001 by Bernard Bauer and Shizuoi. It was transformed in 2007 to the IFNE that everyone now knows and many people are part of. And it is an informal collaborative network to acquire larger sample sizes for studies, basically. And they've done numerous studies, and this was one of them. This was one of the early ones on neuroendoscopic biopsy that Shlomi Constantini led. But the one big prospective study that has been done from this is the IIHS, which is the International Infant Hydrocephalus Study. This was meant to be a randomized trial comparing ETV and shunt in infants under 2 years of age with aqueductal stenosis, and we required many centers around the world to participate in this. And you can see here the centers that did participate. It was a huge group, again, from all over the world, and I'm eternally grateful to these individuals who really did played a major role in getting this study off the ground. There were a total of 27 centers that recruited patients. There were another 8 centers that participated but did not enroll any patients. And as I said, they were from all over the world: Europe, UK, North America, Middle East, South America, and Asia. But all centers were self-funded. We did not have any external funding for this. So anybody who participated did so out of their own goodwill and using their own time, own resources to get the data and to do this study. So there was no extra funding for this. We were just relying on everybody's own goodwill. And over 10 years, our total recruitment goal was to get 182 patients. And we started the study, and more centers came on board. And in the first 4 years, patient recruitment started to look really good. We were at 40 patients per year by year 4. But you can predict what happened, right? We were going up this way, but then look what happened. Year 5, 6, 7, 8, 9, 10, recruitment went really far down. And this was another lesson that I learned, which is that if you're going to do a poorly resourced study, it's going to take a lot of time and it's going to lose steam. Okay, and the reason we didn't have the money to get centers to do stuff in a way that would have kept that recruitment going, and we could have finished this study in 5 years or 6 years, but instead we had to drag it on to 10, and then what happens is people just lose interest. And so this was an example of a failure in a way, right? So we started recruitment in 2004, but we ended in 2013. When our data monitoring board suggested that we should just stop further recruitment because there was no way we were going to be able to complete the study as we had hoped. Because what had happened is not just that the numbers were low, but we had very few patients in the randomized arm. This was meant to be a randomized study, but very few patients were in the randomized arm. Most patients ended up going in the non-randomized arm. And so what we ended up doing then was analyzing all the patients together, not as a randomized study, but just as a simple prospective non-randomized study. And so this was the results that we got. They're not all that important here other than to show the relatively poor results for ETV compared to shunt under 6 months of age. But this was really important to me, having good results for ETV alone in patients over 6 months, okay? Now, this was in a sense a failure because we did not do a randomized trial like we had hoped. But we took the best of what we could. And so we took the data and we've published, I think, some really good works on it. So since then, multiple papers have come out using this data because it's still very good, 5-year prospective data on infant hydrocephalus, which is very valuable data. And so we've been able to do quite a bit with it. And so I think lesson number 3 for me was, in the face of a seeming failure, salvage what you can. And I felt really bad that this ended up not being a randomized trial like I'd hoped. But you know what? It was okay. We still ended up getting some important data, and there's still more to come from this. Now, the Uganda collaboration, and I've talked about this before in my first talk. From my perspective, from a research collaboration perspective, that collaboration began here, which is not Uganda, but this is Hawaii. And I'm showing you this because in 2007, the American Society of Pediatric Neurosurgery met here in Hawaii, and this is where I first met Ben Worf. And we just met by accident over breakfast. And we started speaking and expressed, a mutual respect and admiration for each other's work. And that's how this collaboration began. And this research collaboration that I've had with the team in Uganda has really been one of the most important and satisfying pieces of work that I've been involved in, and which was the other lesson from this, which is never underestimate the value of luck. This meeting, this whole collaboration started because we met at the same meeting over breakfast at this hotel. And so that to me, that was just a fluke, right? And so never underestimate the value of luck in setting up these types of collaborations. And when an opportunity presents itself, like that discussion that Ben Worf and I had, take advantage of it and see what can come of it and what you can make of it. But it helps to be prepared, you know, and we were each prepared. He was prepared because he came to that chance meeting with having done this work and having set up a really good clinical unit. And I came prepared because I had the research background and the statistical background. And it worked together. And what that's evolved into is a unique collaboration involving Harvard, Penn State University, University of Toronto, and Cure Children's Hospital of Uganda. And this began as a clinical enterprise to meet the unmet needs of children with hydrocephalus in sub-Saharan Africa, but then it evolved into an academic and research collaboration. And we've talked before about the randomized trial. I showed you the results of it that were done. But there were other aspects of the randomized trial that I think are absolutely crucial. First is that we had local co-investigators in Uganda who helped guide a lot of the methodology and the day-to-day carrying out of the research, including statisticians there. The study became funded by the National Institutes of Health in the US, which was one of the only institutions that could provide the amount of money that was needed to run this study and to help build the research infrastructure. I showed you the results of this already in my previous talk. But the funding that the NIH gave was actually very important because it didn't just run the study, but it helped build that local research infrastructure. And what that meant is that one of the local MDs in Uganda was able to get training in clinical epidemiology. She got her master's of public health and now has statistical and clinical epidemiology training to do research in a more independent way. As well, we have a local biostatistician there who can help with studies. And very importantly, you know, we did this study with the Bailey's outcome score as being the primary outcome. Well, not everybody can do a Bailey's score. You have to be trained to administer the Bailey's test. And they did not have trained evaluators in Uganda. And so this was one of the challenges that we had, which is how are we going to train the people in Uganda to do the Bailey's test? And I didn't know how that was going to happen. And so reluctantly, I turned to some of our local neuropsychologists in Toronto and said, you know, do you have any ideas? And I didn't expect that they were going to really be all that keen to help, but actually they were really interested to help. And they took this on. And what they did was they thought about traveling to Uganda, but they both had families and stuff, and it was going to be very hard for them to do this. And so what they ended up doing was doing remote teaching of individuals in Uganda from Toronto via Skype, and initially by emails and stuff, and then by Skype, and then observing these individuals in Uganda doing these Bailey's testing, and then watching them until they were doing it properly, and then signing them off as being certified in doing that testing. So that was the lesson I learned from that is that sometimes your best resources are right under your nose and you just need to ask. So I wasn't going to ask our neuropsychologists because I didn't think they were going to be interested in this. But not only were they interested, they did a fantastic job. And this was absolutely crucial to running this randomized trial. Now, the Hydrocephalus Clinical Research Network, this is a big endeavor. And this started when the National Institutes of Health in the US ran a workshop on hydrocephalus research almost 15 years ago now. And present at that workshop was this fellow named Paul Gross. He was an executive at Microsoft, and he had a son who was born premature and had hydrocephalus. And so he was a smart guy, and he wanted to do something to further hydrocephalus research. And at that workshop, he met John Kessel, who everybody knows as you know, a world leader in hydrocephalus and clinical epidemiology and stuff. And they started talking, and they thought that the best thing to do would be to start a clinical research network that's devoted to hydrocephalus. And so in 2006, the HCRN, the Hydrocephalus Clinical Research Network, began. And it began with just these 5 centers here. So Toronto, we were one of them, plus Seattle, Salt Lake City, Houston, and Birmingham. That was in 2006, and it's expanded since, so that by 2016, it involved 14 centers across the US and Canada, and that's how it stands now in 2020. So it's a lot of centers that are participating. And the model for how the HCRN works is that we do multiple simultaneous projects at the same time, okay? And we have investigators and research coordinators at each center that are dedicated to doing this. These are high volume centers. They all have significant expertise in clinical research, and they have a history of cooperation in clinical studies. And of course, they have strong pediatric neurosurgical expertise. And so multiple studies are ongoing in parallel at any one time. We have randomized trials going on. We have prospective observational studies. We have some retrospective studies. We're doing some survey and translational research studies. And then each study is led by a different principal investigator who can be a neurosurgeon at any one of these 14 centers, but that person leads the study and coordinates it amongst all the 14 centers in the network. And just as an example, these are the studies that are going on at a single point in time. So we're doing all these studies at one point in time across all these centers, and they're different types of studies. This is expensive though. It costs a lot of money, and the funding from this comes through philanthropy, so donations to the Hydrocephalus Association. It comes through peer-reviewed grants. We've had grant funding from the NIH and from other sources over the years. And then, but individual centers are still largely responsible for a lot of their own costs with this. And the quality of research is high, but that comes at a cost. And so that's lesson number 6. If you want high quality research, it's going to cost money. It's going to cost money and it's going to cost time. And just to give you an example of the power of this type of research, it is expensive, but the power of it is probably worth it, right? So we have something called the Core Data Registry Project. And this means that since 2006, when we started, every center that's come on board has kept a prospective record of every single hydrocephalus operation they've done. Every ETV, every shunt revision, every redo ETV, every one of them has prospective, detailed intraoperative data. And so now we have over 14,000 hydrocephalus procedures, over close to 2,000 new procedures per year, over 6,000 individual patients, over 800 new patients per year, adding to this. So you can see that this is an extremely powerful resource now for answering questions about hydrocephalus and the surgical treatment thereof. And just as one small example of that is the ETV-CPC data that I've already shown you before. And this was the curve that I showed you in the previous talk. And the HCRN, I think, has been very instrumental in greatly accelerating our understanding of ETV-CPC in North America. Because I think without that, we would be much further behind in our understanding, because we basically only have Ben Wharf's work and the Miami work. Single center works that are very specific types of practices. Our data, the HCRN data, now gives multi-center data across North America on this procedure. And it's allowed us to do numerous analyses of outcomes of this procedure. And that has set the stage for this NIH-funded randomized trial that I told you about in my first talk. There's no way that trial would be happening if it was not for the Hydrocephalus Clinical Research Network. So lesson number 7, sometimes multi-center work is the only path forward, even though it's expensive. Okay, the HCRN is expensive, but I think we'd be much further behind in the topic of ETV-CPC as just one example if the HCRN did not exist. So those are the different ways that the different types of collaborations that I've been involved in. There's others, but I wanted to highlight those. And as I thought about them, one way to sort of categorize them that I think is useful is looking at the geographic scope of the collaboration. That is it just national within the borders of a single country, or is it international, crossing borders? And then what's the academic scope of it, right? Is it just, you're just gonna get retrospective data and do retrospective studies? Or is it you get together just to do a single prospective study? Or do you stay together as a network and do multiple studies in a prospective fashion in an ongoing basis? And as you might imagine, as you move down this grid here, it becomes more resource intensive. It takes much more time, takes much more effort, and importantly, takes a lot more money as you go down this. But at the same time, you get more useful results, potentially more powerful results. So what are the benefits and disadvantages of these types of collaborations when you talk about large-scale multi-center collaboration? So there's a lot of benefits, right? So one is that it ultimately improves the generalizability or the external validity of your results, because you will, by necessity, have had to have more or greater community participation and consensus in the study design. If you want multiple centers to participate in your study, they have to agree to your study. They have to look at the study protocol and say, yeah, this is a good study. So you get more input at the very beginning. And then at the end, you're now getting data from many centers. So it becomes more meaningful and more widely applicable. The other benefit of these types of collaborations is that it's efficient of resources. You can have centralized, non-duplicated resources for things like data collection and storage or statistical analysis and expertise. You don't have to have a statistician at 10 different centers. You can just have one statistician or one centralized database, right? It costs money to run all these things. And then so what that allows is participating centers can use local resources for what they really need to, which is patient recruitment and follow-up, because you can't do that in a centralized way. It's efficient of time, because if you can get more centers involved, then you can get a greater recruitment rate, and that means studies can be completed faster, which means you can get answers quicker. And that gives you the chance to involve high volume centers to get studies done even faster. And it also allows you to minimize the effects of bias. So if you're doing a study that's not randomized, then having more patients in a multi-center study allows you to do better statistical adjustment for confounding. So there's lots of benefits to it. But there's disadvantages too, right? Quality control, it becomes harder. When you've got multiple centers, you can't control their recruitment rates, their patient follow-up protocols. Are they complying with the protocol? Are there protocol violations? How accurate are they getting the data in? And are they entering it in a timely fashion? And so this is where you have to put in effort and money to do independent data monitoring of each of the different sites to see that they're keeping up with accurate, timely data completion and follow-up. The other disadvantage I hinted at the very beginning, which is appropriation of academic credit and leadership. Not everybody who's involved in a multi-center study can be on the steering committee or on the writing committee. But you have to find a way that even those centers whose contribution may appear less visible or less credited, that they do get credit and that they do feel that they're a valued member of the collaboration. And so that's where I said at the beginning, it's important to have transparent a priori agreements in writing as to how people will receive credit for their involvement in these collaborations. And the other challenge that I learned from that IIHS study is maintaining engagement. It can be very challenging to keep all centers and individuals interested in projects, particularly if they go on for a longer period of time. And so all centers, and I think to do that, all centers have to see that there's some benefit to their participation. And usually that means, again, being on multiple papers and stuff, but in some way they have to see that they're benefiting from their participation that may drag on over many years. And this needs to be reinforced at regular intervals. And I'm just going to end with this, and this relates more to the point of international collaborations. And this is a very personal thing, which is, this is a photo of the neurosurgeons at Sick Kids Toronto in 1990. And I put this up here because it shows people that you will know: Jim Rutka, Harold Hoffman, Jim Drake, Bruce Hendrick, Robin Humphreys. And sadly, 3 of these individuals have died. Robin Humphreys just died earlier this year. But these were the neurosurgeons who were working at Sick Kids in 1990 when I was a first-year medical student. Before I knew I wanted to be a neurosurgeon, but once I started working with them, I knew I wanted to be a pediatric neurosurgeon. And the reason was, of course, they were Canadian, and I was incredibly impressed and in admiration of them. But when I was at Sick Kids then as a first-year medical student, there were trainees there from all over the world, from the UK, from Brazil, from Israel, from Japan, from the Netherlands, from Saudi Arabia. And I got to know a lot of them very well, and some of them are still my very good friends to this day. And as a first-year medical student, I realized in pediatric neurosurgery, you can work in Toronto, but you can collaborate and really be friends and work with people from all over the world. And I absolutely love that. And to now give this talk 30 years later is fantastic, because it reminds me that we should be grateful and never forget how lucky we are to be able to work with people and meet with people from all over the world. And so here I am in Canada. We don't have pyramids and camels, but we do have mountains and moose. And I'm giving this talk to you in Egypt and around Africa. And it's an incredible honor. And it reminds me very much of why I'm so lucky and glad to be a pediatric neurosurgeon. Thank you very much.
Thank you, Kulkarni, very much for your talk. And Omar now is going to, first of all, get the questions from the panel, and then we open discussion among all panelists.
Thank you, Dr. Khan, for this distinguished talk and a very valuable experience. Here I will search for the question. There is a direct answer from direct question from Nasser Muhammad Said. Please unmute yourself. Nasser Muhammad Said, please unmute yourself. And another question from Hosna Abu Rafiq, please unmute yourself. Okay. Okay. Until they join us and until they unmute themselves, we can start a discussion. Start with Dr. Hisham Basyouni. He's an Egyptian German neurosurgeon. Welcome, Dr. Hisham.
Welcome. Thank you very much.
Thanks for your joining us this webinar, this session. We would like to know your personal experience using the endoscope in the issues of pediatric problems and the German experience as well, please.
Well, thank you very much for these excellent talks. I learned a lot, and the last talk, of course, was summarize. Not restricted to hydrocephalus. It's actually to every scientific topic. So it's very interesting. Also, the talks showed that we all got the same problems with hydrocephalus. It's no difference in Germany to the experience in Canada, to the experience in Egypt or Italy or anywhere in the world. Treatment of hydrocephalus can be simple. It can be simple and successful, and it can be very complicated. Fortunately, in my experience, the latter is rare, but it can be very time-consuming and can make problems not first of all to the patient, but also to the doctor over years, especially in children. Actually, the treatment is in Germany is no other than as you have shown. The problem of course, for example, NPH, the most common hydrocephalus I see especially in the elderly population. It's the diagnosis is difficult. And treatment seems simple, but it may be quite difficult because of course you can get problems with subdural effusions, either chronic subdural hematoma or hygroma. So this can be quite difficult. In the treatment and endoscopic treatment of hydrocephalus, as you have shown, it can be a rescue treatment or emergent treatment in the acute hydrocephalus, obstructive hydrocephalus, in order to prevent an external ventricular drainage. And if it seems that treatment will be more lasting for the future, you can put in external ventricular drainage, of course, and remove it after surgery, after you have removed the cause. So it's actually no difference, and the indications are the same as you have shown. Maybe I've got a question in the choroid plexus coagulation to Professor Kulkarni. Excellent talks, thank you very much. Have you studied the incidence of course, in small children you have got no cognitive information, you have got no examination, or at least to my knowledge, how to, as you've got in the adult patient about the memory deficits and so on. But have you studied an MRI on MRI follow-up the injury or the lesions or possible lesions to the fornix or to the thalamus while you are doing this choroid plexus calculation? This is what I thought of.
Yes, that's a great question. So we're there's a couple of ways to answer that. So within the HCRN, we have looked at intraoperatively whether there's gross evidence of injury to the fornix or thalamus during surgery. So we do record that. But that's just a surgeon recording of it, which isn't particularly accurate. So that's obviously not the best. We have not as yet had the data to look at detailed MR follow-up for injury, but that is part of this current randomized trial that we are doing. So we're going to have a very detailed MR preoperatively and postoperatively that will have diffusion imaging on it as well. So we will look at predominantly white matter injury, but I think we'll be able to gather from that if there's other subtle evidence of thalamic injury also. And because that study has as its primary outcome cognitive outcome, we'll be able to correlate that type of injury to cognitive outcome. The issue is that these are all babies. So as you noted, the cognitive outcome for a 1-year-old or a 2-year-old, it's a limited assessment. But we are going to follow them till age 5, when we will be able to get a more rich assessment of their cognitive status.
Yeah. Thank you very much.
I have a question for Professor Kulkarni. Kulkarni, I was contributing to the members of directors of the WNS in San Diego in April 2019. And we were discussing the issue of neurosurgical education in Africa. And that's something very important. And you know as well that I'm the honorary secretary of the Continental Association of African Neurosurgical Societies. And I found a lot of collaboration between Duke University and Uganda. And today I realized that there is a lot of collaboration between you and Uganda. My question is that why Uganda especially? And if you have any other collaboration in research or neurosurgical education in other sub-Saharan African countries or no?
I personally don't. These things happen just by, I think, more by chance, right? It's people who have met and know each other and then have some sort of a connection to one specific area or not. I know that there are multiple centers across North America that have worked in many different parts of Africa, and people who are participating in this webinar may know some of these offhand or have experience with them. So it is, there's nothing specific about any given country other than the organic and largely fortuitous nature by which these collaborations have developed. I'd be remiss not to mention that William Harkness has started with the ISPN, the Intersurgeon website, which is meant to be sort of a repository for all centers that are willing to collaborate around the world. And so one can go there and look for centers that are seeking collaborations and develop networks and teamwork that way, because it is hard otherwise to make these connections.
And I think you have to think about other countries too. In sub-Saharan Africa, really the situation of neurosurgery is not advanced. And I realized in my last publication, I published in the Neurosurgical Focus in March 2020, I was putting the number of neurosurgeons in sub-Saharan Africa. And I realized that in 13 African countries, about 13 countries, there is not a single neurosurgeon. We have definite problem in neurosurgery in sub-Saharan Africa. And we need to collaborate together, and it needs a lot of hard work about all organizations in Canada, in USA, in Europe. But that's one of the most important targets, and I think the World Federation of Neurosurgical Societies have given a lot of attention to the African continent. And I spoke with Nelson Oyasiko, who is the president-elect, who is going to start soon next July to be the president of the World Federation, that much of attention has to be paid to the African continent. We would like to work together, to collaborate together in order to raise and to develop the neurosurgical standards in sub-Saharan Africa especially. When you look at Africa, you find that Africa is concentrated mainly in the north and in the south. And I would like to tell you that African neurosurgeons constitute 1/3. Egyptian neurosurgeons constitute 1/3 of African neurosurgeons. We have a lot of facilities, we have many centers, we have all the subspecialties. And in my publication, I raised a very important point that one of the most important obstacles is the lack of communication between the African countries and each other, and between the Africa as continent and other continents as well. And that's very important. I developed the website, I developed e-hotline, hoping that such websites and such technology of e-hotline will promote the neurosurgical education and collaboration and research in Africa. I think, Kulkarni, on behalf of CANS, I will be very happy to communicate with you, and I will speak to the president of CANS, Mahmoud Khorashi, that we can communicate with you, because you know that global neurosurgery now, one of the most important things is hydrocephalus and TBI, the traumatic brain injury. These two important issues are the main important issues. We have a lot of hydrocephalus in Africa. We have a lot of hydrocephalus in Egypt. We are able to see very rare cases which are almost not available in many centers worldwide. We need to focus and concentrate our efforts. We need to communicate, and CANS will communicate with you to see what we can do together about hydrocephalus in Africa, mainly in sub-Saharan Africa.
Extremely worthwhile endeavor, very important, and I'd be happy to help out in any way.
Okay, this is a good and open invitation from Dr. Nasser to all of the eminent neurosurgeons to valuable experience and to improve the standards of the neurosurgery in Africa and sub-Saharan Africa. We have here questions from Muhammad Nasser. There is from Nasser Muhammad. He asked about the age limits of TV. Is it 3 months?
Professor Alberto?
Okay, can you hear me?
Yes, of course.
Yes. There is not how can I say, a state limit of 3 months. Many authors started to perform endoscopic ventriculostomy also under 3 months, but the results are not good.
Thank you. Omar, can you ask about Professor Osama Al-Ghannam and Professor Assam Gabr if they are joining us in the panel, if they would like to say any comments?
Dr. Osama, are you here, Dr. Osama? Dr. Osama Al-Ghannam? Dr. Assam? Dr. Assam Gabr, are you here? Please unmute yourself. Dr. Assam and Dr. Osama, please unmute yourself.
You hear me? Can you
Yes.
listen to me now?
Yes,
Yes.
Dr. Assam, welcome, Dr. Assam.
Thank you very much for this outstanding webinar.
Dr. Assam, he is a professor of neurosurgery in Alex University, and he is especially specialized in skull-based surgery. But please share your experience and your questions, please.
Actually, I'm very happy with this webinar. I benefited a lot. It's very outstanding. All professors who talked are very eminent. Experiences are a lot. And actually, I was about to ask the same question, the age limit of the endoscopic third ventriculostomy, and this was a current question, so I was listening to it.
Yes, please, all the professors on the panel, do you have any age limits? Dr. Kulkarni, Dr. Nasir, Dr. Dilatala, Dr. Hisham, do you have any age limits? Are you stick to the 2 years age limit or not, please?
No, I would use it varies, right? It depends not just on age, but a combination of the age and etiology, and then you have a discussion with the family about the pros and cons of it. So there isn't a specific limit. It's individual, and you just have to take added risk when the patient is a bit lower. That's all.
That means, Dr. Kulkarni, you have the option to do ATV at any age, even with different pathologies, just to try to solve the problem of shunt dependent. That's right.
Yeah, I mean, I don't want to say that you just do it in everybody and don't care, because that's not what I mean. What I mean is that if you have a 2-month-old who in Toronto has post-infectious hydrocephalus, the chances of ETV success in that baby is very, very poor. And I would not recommend it in that, okay? But a 2-month-old with myelomeningocele, that's a patient that I would do ETV CPC on, or at least suggest that it's a good alternative to shunt. But that would involve a discussion with the family. We'd have a discussion about the pros and cons of those.
And that's the same with the same age limit and same prerequisites, and talk with the family about post meningitis and encephalitis, cysts, and all of this, not only third ventriculostomy, and also cyst surgery, multiple cyst surgery. The same age limit, or you can go at any age if there is multiple cysts that needs endoscopic fenestration and communication with each other.
If that's for me, yes, I agree. I think well, often with these, as we just heard from that excellent talk from Dr. El-Ghandour about when you have multiple cysts, usually these children end up getting a shunt as well, in addition to the cyst fenestration. But for these young children, I think you do both, and the cyst fenestration endoscopically is very important for them, regardless of how young they are.
That's great. Thank you very much.
Let me also say my opinion. I agree with Professor Kulkarni, and I usually like to do endoscopic third ventriculostomy, and in most of the patients, because I hate putting shunts. I hate putting tubes intraventricular. I have very bad experience, and we had very high incidence of shunt malfunction and complications. And I think when we speak about the neurosurgical training, I sent a proposal to the World Federation of Neurosurgical Societies. This proposal was saying that I would like to make endoscopic third ventriculostomy a basic procedure. Because what is the difference technically between doing endoscopic third ventriculostomy and between doing ventriculoperitoneal shunt? Why endoscopic third ventriculostomy has to be done by senior neurosurgeons, and at the same time, the resident can perform ventriculoperitoneal shunt? I like to make it a basic procedure. That's why usually I would like to focus in the workshops about classic procedures. I totally believe that for young neurosurgeons, if they can elaborate doing the endoscopic third ventriculostomy, that's very important to know how to do a basic procedure like this. If we succeed to make it a basic procedure, which can be done in emergency, which can be done in all the centers of neurosurgery, whether in Africa or anywhere, I think we will succeed to avoid complications, thousands of complications. We are going to save a lot of money. because really I hate inserting shunts due to bad experience with complications about shunt malfunction and complications.
And Dr. Dilatala, please, your opinion. Do you have any age limitations? Yes, please.
Well, I'm completely agreed with Nasser that also the VP shunt is a serious operation and it requires good technique. Remember that the majority of malfunctioning of the ventricular peritoneal shunt is the peritoneal absorption of the CSF. And we have not to forget that there is also the ventricular atrial shunt as an alternative. But coming back to the limited age, I want to show you again, my a part of my presentation. Yes, in this slide. In this slide, they divided, I don't know if you can see, they divided the series into two groups, and one group inferior are 6 months, and one group superior to 12 months of age, and there was demonstrated better outcomes in the older age group. So this is a common experience of everybody, but it is also correct to try, because to live to try with third ventriculostomy, because to leave a baby without shunt, free from shunt, is a great value, and this is up.
Yes, and thanks, Dr. Tirata. Dr. Hisham, do you have any age limitations?
Well, the same experience, no age limitation, but the younger, the more difficult technically, and the more complications. And more non-success rate. And we have to remember that the VP shunting is often a cause for the multiloculated hydrocephalus because of infection, as a result of infection of the shunt. So it is a serious surgery. It has to be done very carefully, very accurately, and in order to prevent these complications, which are complicated complications, not easy to treat, and you actually transform this single chamber hydrocephalus into a multi-chamber and multiloculated problem, actually. So this has to be prevented, and whatever means you can do to prevent this without shunting, so that's of course preferable. But the younger the child, the more complicated is the third ventricular.
This means this is a consensus from all of you that the age limitation is 2 months. Above 2 months, we have to try to take the chance of success. Below 2 months, I think is still a strong limitation. Is it true?
Yes.
Yeah.
Generally speaking, we can say like this, Omar.
Yeah. Dr. Diritala, are you agree for that?
Yes, I agree. Remember that there is a curve in which less is the age, less are the results.
Dr. Kulkarni, are you agree that the absolute age is 2 months?
No, I think that was my point, that I think that there are exceptions to that. When you do with the ETV CPC data that I was showing, I think there are exceptional circumstances where you can go under that, but it's not just, you're not doing it just because, and you're not doing it just because shunt is so bad. You're doing it because the data can support a reasonable chance of success in a very, very limited group of infants. It's not everybody. It's not that simple. I don't believe it can be simple one sentence. Here's the age limit. Below it, don't try it. Above it, try it in everybody. To my mind, it just does not work that way.
Okay.
Other factors are important as well, Omar. Age is one of the factors, but it's not the only factor. Other factors also are affecting the outcome. I think by answering this question, do you have any other questions?
No, there is a question. Yes, from
Okay.
Pablo Valinova. He said there is an old statement that once shunted, always shunted. What's your opinion for that? Is there any other way of solution in a dysfunction context? Would you advise for an endoscopic revision or solution? Please, for the panels. Dr. Dilatala?
In obstructive hydrocephalus, in case of shunt dysfunction, we try endoscopic third ventriculostomy.
Dr. Kulkarni?
Yeah, I agree. I think anytime there's a shunt obstruction, you should think about the possibility of doing ETV as a rescue procedure for that patient. But it depends on various factors, including the anatomy of the ventricles at the time. But certainly, just because somebody's been shunted, I don't think it means you never try ETV. I think there are certainly cases where you can try ETV.
Dr. Nasser?
Omar, I don't agree with this statement because I have many patients who came to me with shunt complications, and I did ventriculostomy, and the shunt was removed, and the post-operative course was very good. I know there is a problem of shunt dependency, but it's not existing in all the patients.
Dr. Hisham?
I think it's important to say or to point out that if you remove a shunt, you must have an alternative. Because it should not be understood that you can remove long-standing shunt because, for example, apparent disconnection. Because we are usually these patients have had shunt for years. And also we know of cases, I think we all know of cases that a shunt was erroneously removed without replacement means without an alternative like third ventriculostomy, removed because it was thought of non-functioning and not anymore necessary, and the patient deteriorated, and some of these patients died actually because they were not observed. So it has to be stressed out that even if there is an apparent disconnection, you can have a tract actually where the CSF goes through without the shunt being continuous, for example. So if you are thinking of removing a shunt which deems not to be necessary, you have to do it very carefully. Or if it is necessary, of course, you can choose the more modern, because we are usually talking of patients who had for decades. You can use the third ventriculostomy, but in either case, you have to observe the patient very carefully if whatever measure you are taking is successful and leads not to a deterioration of the patient.
Me personally, I have a couple of cases that succeeded after ETV and either just to remove the proximal tube under the endoscope, or if it's difficult, I leave the shunt and just make sutures on the distal tube on the neck, and it succeeded actually. But
you performed the third ventriculostomy.
Yeah.
Yes. That's what I mean. You have to either perform an alternative, but you should not.
That's right.
But you should not remove a shunt without alternative and think that it is not necessary because it for example, it looks like disconnected or is looks like non-functioning, because this is maybe a fatal error for the patient.
Yes. Doctor,
Professor Omar, can I have
yes, please.
another
Yes,
question?
please. Yes, please, Dr. Assam, please.
Okay. I attended with Professor Omar Hamad an excellent workshop on endoscopic third ventriculostomy, and we talked actually a lot in hydrocephalus and management, and we found that the CSF circulation differs after third ventriculostomy and the direction of CSF rather than the ventriculoperitoneal shunt. And Dr. Hamad showed us many cases in which he did actually aqueductoplasty. And after doing this, if I can remember, if I'm wrong, correct me, Professor Hamad, and the aqueductoplasty closed. And we were talking about the CSF dynamics in the ventriculoperitoneal shunt is known from up down, but in cases of third ventriculostomy, the CSF dynamics may revert in some cases. And the dynamics, the pressure decreases to the extent that the aqueductoplasty, what I understood, closed after adipoplasty. If there is any comment from professors who are eminent and experienced in that, including Professor Hamad himself, because he's the one who showed us this. Thank you.
Thank you, Dr. Assam. My opinion, just I have only 5% success with the aqueductoplasty for these cases of obstructive type. I don't know about the other professors. Please share your experience, please. Yes, Dr. Kulkarni, please.
I don't use aqueductoplasty, so I don't really have much experience to comment on with that.
And Dr. Delitala?
We don't use aqueductoplastic because we think is not completely safe, and the recurrence is high. We just explorate the aqueduct if there are clots or masses into the aqueduct.
Dr. Nasser?
Omar, what is the question you ask? If
Hey, Dr. Sam will speak about the different options using ETV, either aqueductoplasty and the change of the CSF cycles and the reclosure of ETV or either reclosure of aqueductoplasty. All of these issues.
that's very complicated issue about the cerebrospinal fluid dynamics, and until now I don't think that it is clear 100%. But generally speaking, I'm not using aqueductoplasty as a surgical procedure. I don't know. I'm agreeing with Alberto and Kulkarni that such procedure is not a safe procedure, and I don't have experience about this.
Dr. Hisham?
I think in acute stenosis, you have to see where it is located. So with the MRI, you can see it quite well. And I had cases where I did it microsurgically, where I did open in the upper part of the aqueduct. I opened the web, which was occluding the aqueduct, and at the same time, because I was not sure if it was reclosing, I did a microsurgical third ventriculostomy. So I did both, but I did it microsurgically actually, not endoscopy, and it worked. So the patient is patients usually present with headache and also some cognitive function disturbance in concentration. And there's an obvious hydrocephalus on MRI, which needs not to be acute. It's usually chronic in these cases, but it worked. But to put to put a foreign body, as I understand the aqueductoplasty in the aqueduct. I did not.
It's a quite valuable discussion.
Omar,
Personally, I got a good benefit, and I think Dr. Nasser, we have no more questions in the Q&A and the chat. There's no more questions.
I think it's time to close the webinar. It was one of the most successful webinars we had among our series. At the end of this webinar, I would like to thank our distinguished speakers, Professor Alberto Dell'Itala, Professor, and he's my friend and brother, and he's president of MANS and former president of the Italian Society of Neurosurgery. And I would like to thank Professor Kulkarni from Canada. You honored us by contributing to this webinar as speakers, and your talks were very wonderful and stimulating to all of us. I would like also to thank Professor Hisham Bassiouni, Isam Gabra, and Omar Youssef for moderating this session and for this fruitful discussion. I think it was very, very successful webinar. And thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time and experience. Thanks to all attendees. Thanks to Eva Pharma. Thanks to IT, Ahmed Magdi and eHotline. I would like to announce that next Friday, we have Professor Osama Al-Mufti in webinar number 22 among our series. And see you next Friday. And I hope that we can do a lot of collaboration in hydrocephalus with Alberto Dell'Itala and with Kulkarni. It's very important. It's one of the most important issues in neurosurgery and in global neurosurgery. Hydrocephalus is a global neurosurgical problem. Let us work together and collaborate together and teach our young neurosurgeons. And this is going to be for the benefit of all our patients in Africa and all over the world. Thank you very much and hope to see you again soon. Thank you.
Thank you, all of you. Thank you. Bye. Thank you.
Thank you.